Society for Vascular Surgery, under the leadership of Richard Cambria and Peter Glavitsky, has initiated an audiovisual interview process with the pioneers of vascular surgery. This is part of an effort by SVS to develop archives to preserve the history of SVS as well as vascular surgery as a specialty. A committee was formed called the History Project Work Group, chaired by Jimmy Yao, with Norm Rich and myself as members. Cal Ernst served as consultant. Because of the workload, an expansion of the committee was needed. William Baker, Mark Eskandari, Walt McCarthy, William Pierce, Melina Kibbe, and Peter Lawrence were added. Since the program was initiated in November 2011, we've interviewed some 50 leaders. SVS has recommended that the interview process be extended to honorary members of SVS as well. My name is Roger Gregory, and today we will be interviewing the legendary Australian vascular surgeon, James May. Jim, thank you for agreeing to this interview.
That's my pleasure, Roger.
Jim, let's start with your early days. When were you born?
I was born on the 9th of May in 1934.
And born in Australia?
Born in Australia, yes.
Whereabouts?
At a town called Gulgong, Gulgong, and that's about 200 miles northwest of Sydney. It was famous in the gold rush days.
Tell us about your parents, your mother and father.
My father had a hotel in the town, and my mother was probably one of the kindest and most thoughtful people that I've ever had the good fortune to have a lot to do with it. It was a very strong influence on my character, I think. And my father and I got along well together. I had two siblings, and they were 9 and 10 years older than me, so I had less to do with them than I did with my parents.
Tell us about your early schooling and how this is structured in Australia.
It's structured in two forms. The primary school, which goes up to sixth form, which is probably age 12 by the time you get to sixth form, and then secondary school, which goes from age 13 up to 17 or 18, and that's 6 years. And I did my primary schooling at the local public school in Gulgong, and then I had my secondary schooling at Cranbrook School in Sydney.
Now, did you go straight from there to university, or exactly how is that arranged?
Yes, you in Australia you sit for what used to be called then the leaving certificate, and that was also used as an assessment for gaining entrance to the university. And at that time there were Commonwealth scholarships available for tuition at the university if you achieved a satisfactory level.
Now, were you thinking about medicine at that time, or?
No, not while I was
early on
at school. In fact, I I was in my last year of schooling, but I had not been thinking of that earlier on.
What got you interested in medicine?
I think it was somebody had mentioned to me that you should look at where your talents lie and try and fit those in with your future career. And I was stronger in sort of science and maths. Not that I was terribly strong in those either, but they were certainly better than the humanity subjects.
Now, you finished the University of Sydney in 1958 with an MB and a BS. Now, what does that mean?
Bachelor of Medicine and a Bachelor of Surgery.
Is that the same as a MD degree would be in the States?
Yes, it would be.
Then you got a master's degree in 1979.
Right,
Considerable time after you finished and had an MD degree.
right. That was because both the Master of Surgery at that time and the Doctor of Medicine in most Australian universities are degrees that you need to do research and have them awarded there. So there's a difference, I think, between Australia and the United States as far as...
Right. Now tell us about your surgery training.
My surgical training took place at the Royal Prince Alfred Hospital, which is the campus hospital for the, or it's on the grounds of the university, with them being adjacent, which was where I had applied to go to, and fortunately got there, and that was an advantage, I think, to have a university association from the very outset.
After your first year or two, then you became a surgical registrar.
Right.
At the same hospital.
That's correct.
Now, in 1964, you went to become a research fellow at the University of California in San Francisco. How did that come to pass, and who did you work with there?
It came to pass because I wanted to do some research work full time, and my mentor in the Royal Prince Alfred Hospital was the Professor of Surgery and head of the Department of Surgery at the university at the time, and that was John Lowenthal.
Right.
He was later knighted when we still had honours based on the British system rather than the Australian system, and he was friendly with J. Engelbert Dunphy,
Right.
Who was at that particular time head of surgery at the University of Oregon in Portland, and he was happy to take me into the research laboratories there. But by the time elapsing between when he agreed to do that and when I was planning to go over, he'd already applied for and been appointed as head of surgery at the University of California in San Francisco, and that was how I came to go there.
Was that a good year?
Oh, it was wonderful. I mean, it was such an eye-opener after what we had in Australia at the time, and there's still a vast difference between the facilities and so forth.
Now, you then spent time at the University of Manchester in the UK.
Right.
What was that about?
Well, basically, I wanted to become a vascular surgeon before I left the shores of Australia, and I had the opportunity in California to work either in vascular, gastrointestinal, cardiac, or transplantation, and because transplantation seemed to be the most interesting from the point of view of what was happening there, that I chose that, even though I did not ever envisage being a transplant surgeon, and indeed I didn't envisage that it would ever become a reality as rapidly as it did. To my complete surprise, by the time I returned to Australia, all the people in the renal unit were jumping up and down wanting to start dialysing and transplanting people. So I was really hijacked into doing that for about a decade before I managed to get back to doing vascular full time. So in answer to your question, I was going to the University of Manchester to work with Boyd, who is the Professor of Surgery at the University of Manchester then, and Ken Bloor, who was the senior lecturer at the time.
Was that valuable time for you, do you think, Jim?
Compared to the United States, it wasn't really. They were pleasant enough people, and the clinical work was fine, but the time I spent in San Francisco was far more valuable.
Right. Let me move from your training to family. When did you get married, Jim?
I've been married twice. I was married initially at the end of my intern year, and then subsequently in 1994.
You mentioned you have some teenage youngsters now.
That's correct.
How many children do you have?
Two from the first marriage, and two teenagers from the second one, both girls.
Wow. So you have your hands full for sure.
Yes, that's very nice though, because
Of course it is.
I think having much more time now than I ever did when I was in training, it's made a big difference.
Now, did you have to do any military service in Australia?
Yes, I had to do national service, which was 6 months in total, and that was spent in a period between first year and second year of my undergraduate training, and then over the following 3 years you had to do a month in camp there.
Now, when you finished training and wanted to enter practice, why did you choose academics, or were there other choices for you?
Yes, in fact, I didn't choose academic surgery straight off, although the opportunity was there because John Lowenthal was still the head of the department, and he was in fact wanting me to do a university or have a university career, but at that time there was a huge discrepancy in pay or income between an academic career and private practice, so that was the dominating thing that
Right.
led me to do that. But in point of fact, there, as it turned out, there wasn't a whole lot of difference because I was working pretty much full time at the hospital because of the commitment of vascular and transplant surgery, so that I had the opportunity to do quite a bit of research at the time, and it turned out really to be advantageous because the association with the renal unit and the transplant work had some spin-offs which were quite challenging and enjoyable from the point of view of satisfaction that you got from them.
By 1979, you were the Bosch Professor of Surgery at the University of Sydney, a position which you still hold at the present time.
That's correct.
And by 2006 to 2010, you became Associate Dean.
Right.
And aside, John Harris had joined you as a partner.
Right.
And I believe he was trained in the U.S., wasn't he?
He was, yes. He was with John Bergen and Jimmy.
Right.
Yeah.
Right. So that's where the connection
Yes.
comes in there. Jim, let me mention some of your honors and achievements, which are, when listed, are rather startling. You became the Companion in the Order of Australia in 2001, which is the country's highest honor. How did that come to pass?
Well, it was awarded primarily, I think, for the work that I had done in endovascular
Right.
surgery, although the work that I had done in transplantation and access to the circulation and so forth also contributed to it.
You had an impressive number of appointments as well, both through the Australian College of Surgeons, as well as government appointments, external examiner, the only Australian on the editorial board of JVS, I might add, president of the International Society of Endovascular Specialists, president of the Australian and New Zealand chapter of ISCVS, president of the International Society of Cardiovascular Surgery, and I might add, an honorary member of the American Surgical. Not many Australians hold that honor, as well as some 400 publications and multiple book chapters. I might mention also some of your firsts as state champion in the 110-meter hurdles, first to report a loop AV graft for hemodialysis, the reversal of renal failure and hypertension by revascularization, first stent graft for false aneurysm in 1993, stent graft in 1995 for treatment of a dissection of the descending thoracic aorta, and in 1997, an endograft repair of an internal carotid artery aneurysm. This is obviously wild success. In the face of all that, did you have any failures or disappointments?
Yes, I think my greatest, the lowest point in the whole saga was the disappointment of angioscopy. I can remember spending a year organising funding to buy an angioscope, and I was planning to use it to inspect the inside of the artery after carotid endarterectomy. But the inability to get a clear field to look at it was rather like trying to look through a really good Californian red wine. That was about the view that I got. And to make matters worse, I lent the angioscope to Richard Waugh, who's the interventional radiologist that I worked with, and it came back after his administrations with about a 50% loss of fibres that made the view even worse. So that was disappointing. And the other thing that I was very sorry that didn't, or that the company didn't press on with, was an aortoscope that was it Gordon Hyde in Kentucky?
Yes.
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 Gordon, yeah. That he was working on, and that was a device that had a transparent balloon over the end of the telescope, and that could be inserted through obviously an artery of sufficient size in the upper limb, and when you got it down, you could inflate the balloon, and that would move the blood out of the way, because the transparent balloon would be pinned back against the wall of the aorta, and you could see the orifices of both renals and in fact the whole thing, and the bifurcation down the bottom. And unfortunately the company that was doing it was uncomfortable that they could guarantee that the balloon on the end of it wouldn't become detached.
Jim, with all this success, have you ever reflected as to why this happened to you?
No, it's been a cause of wonderment to me, because it's mostly happened that people have suggested that I should apply for something or go along a certain path, and I haven't always thought that I was the best person for the job, so I can't answer that question.
That sounds like a pretty honest answer. Yeah, particularly with regard to time management. Do you have any tips that you could offer?
I'm probably the last person to to talk about time management, in that I'm a great procrastinator, but it doesn't ever flow through to the point where I can't make deadlines, or it's unusual for me to miss out on deadlines. But it's certainly not an easy thing to do, I don't think, in surgery, to allocate time for all your work commitments and what you'd like to do for your family commitments as well.
Difficult balance sometimes. At this point, Jim, we'd like to refocus and re-talk about some of the highlights of your career in a little more detail. The first area that I'd like to talk about is renovascular issues. That it came to pass that you were the first to use revascularization to restore renal function and to normalize blood pressure. How did this happen, or why did you think of doing this?
I think it was really from the association with the renal unit that came about. And it's hard for us to believe now that, as late as 1972, that there was just a general acceptance that that if you had a thrombosed renal artery, that the kidney was not of any use.
It's a fait accompli.
That's right, and it was from my association with the renal unit, I think, where biopsies were always used to look at firstly for the diagnosis of what renal disease the patient's renal failure was caused by, and it seemed a logical thing to in somebody even with chronically occluded renal arteries to look at what the cortex was like. So I did open biopsies on the kidney, and you could see that many of them were as people would expect, where there was scar tissue and not much else, but in a proportion of them there were viable glomeruli and tubules, and those were the ones that responded to revascularization, and that was the story, really.
That was startling stuff at that time.
Yes, it was. It was very exciting, because the first patient that I did had bilateral occlusion of the renal arteries, and when we biopsied the kidneys, only one of them had viable glomeruli, which we did a aorto-renal bypass, and much to my disappointment, there was no urine at the end of the operation, but in the middle of the night, she started with a huge diuresis that had to be sort of compensated for with appropriate fluid, and that was pretty exciting.
Another focus area that we'd like to talk about and expand on a little more, Jim, is the aortic stent graft. And I know that you got some initial training in Utah with Dr. Peter Lawrence and his unit there. It just happens that we happen to have Peter Lawrence here today to talk about some of those times in the past. Peter?
Well, Jim, it's nice to see you again. And although I will correct the record, I didn't do any training of you, but we actually did meet in Salt Lake City when you came to learn, as I remember, about 25 years ago, how to put an endograft into a pig, I believe it was. Why don't you tell us about, first of all, how you happened to get to the Utah Biologic Testing Lab in Salt Lake City, how you were selected, or how you got your interest in this whole new area, which was the aortic endograft or aortic stent graft, because at that point it had never been put in a patient, as I remember.
Yes, with the help of the team that we had there, which consisted of Jeff White, Richard Moore, interventional radiologist, and John Harris, I had a patient that we put an endovascular graft into in May 1992, and that was quite an exciting thing to actually be able to get it into the patient and have the graft where he wanted it to be. And one of the things that attracted me about Juan Parodi's model, which was what we constructed our endograft from, was that all the components that I used to make the endograft on that occasion and subsequently were all material that had been used in vascular surgery for several years and was tested. So from the ethics point of view, it made it much simpler in the sense that I wrote to the chairman of the ethics committee at the hospital and told him what I was planning to do, which was to use this material in a different way, but it was still material that had been in use. Even the stent was in use for at least 5 years, I think, at that stage. So that simplified that aspect of it.
When you think back about the origin of the endograft or stent graft, there were really, as I understand it, 2 or 3 people working on this independently. You mentioned Dr. Parodi in Argentina, then I believe that the patent for the device that you put in was Harrison Lazarus in Salt Lake, and then there was a Russian surgeon who was also. Do you have a sense of who came up with this idea first, or were they talking to each other, or how did it happen that people came upon the idea of, in some ways, thinking about it, putting fish hooks on the end of a graft that we used to sew in, crunching it down and putting on a catheter? Seemed like a pretty radical concept at the time.
Yes, although there were animal studies that had been done, which Juan Parodi, I think, was involved with some of those, and they were published, so that there was certainly, there had been work done to show that it should be possible to do it in a human, providing you could firstly get an endograft that you could get into a low enough profile to fit it into a delivery catheter that it still fit inside an iliac artery, and that in itself was difficult at the time, because Juan Parodi was fortunate that he had a colleague called Hector Baroni in Buenos Aires, who was able to make a very thin knitted Dacron graft for him, which was very valuable because when it was furled up, it could be fitted in a much smaller delivery catheter. The one that we used, by the time you added sort of 3 millimetres for the underlying balloon, because it was a balloon expandable stent, then added a stent to that, and then the standard Dacron on top of that. It came to 24 French sheath was the required size, but that was a 24 French internal diameter, so the external diameter of it was 29 French, which was almost a centimetre in diameter, so it was a fairly huge sheath to be putting into the patient. And it took a while to, you were asking about how much cooperation that there was amongst those that were working in it, and there was a lot really in that, even just something that you wouldn't be aware of unless you were told, and that was the need to put the trocar, or the dilator of that was on the inside of the sheath, into very hot water for several minutes to make it malleable enough to get it around. If you'd used it in the cold state, you could do all sorts of damage with it, I think, and that information I gleaned from the San Francisco cardiovascular team, and I'd also visited Juan Parodi in September in 1992. That was after we'd, I think at that stage, had done 3 endovascular repairs, and Juan was incredibly generous with his time and with his information, as far as you know, not sparing anything at all that he knew about it, and spending an incredible amount of time drawing diagrams and explaining things to me, and I also had the opportunity to meet Hector Baroni and discuss the type of material that he was producing and so forth. So there was a lot of cooperation.
Was Juan Parodi then, in your mind, the first person to put an aortic endograft into a patient? Was that the first procedure done in the world?
I have a reprint of an endograft that was done by Volodos, and who was from the Ukraine, and he had published this in a Russian journal, and that was the endograft in that particular patient was placed in the lower descending thoracic aorta, but Parodi was the first person to use an endograft in the abdominal aorta.
So Volodos was another one that was sort of, they were competing as far as time. Who do you think, everybody wants to know, who was first as conceptually? Who do you believe thought of this, or did it happen simultaneously at several different sites in the world?
Juan Parodi had been thinking about it back in the 70s even, but did not have the I think the contact with Baroni or with the stent that he required until the late 80s. So that was I think the limiting factor there. And I think that he was the only one that was near doing it clinically when he did. I don't know the history of what Volodos was doing, except that the reprint or the copy of the publication that he had was in the late 1980s, I think. So it was around about the same time.
So it sounds like Parodi had been thinking about it for a number of years. Volodos may have preceded him by a short period of time in putting it into a patient, but in fact the concept of it may have been in Juan Parodi's mind before it was in others. Is that the way you would interpret it?
That's the way I've interpreted it, yes.
Now, we've heard you talk about the follow-up of patients and the importance of monitoring, because I believe you reported like a 25% chance of endografts needing some modification throughout their life. Is your sense that this will be a permanent solution as the technology gets better, or do you think patients will always need to have touch-ups of their endograft over their lifetime once they have it put in? In other words, how important to you today is monitoring in these patients?
I think it's still important because there are some things that we can't change. For instance, many of the reasons to touch the endografts up is related to the fact that the aneurysmal disease is occurring either proximal or distal to where the endograft has been placed. So I think that there'll always be some problems, and I can see in the thoracic aorta, even this morning when we were listening to the presentation by Ron Dolman about the movement in the ascending aorta and the arch of the aorta, which has also been documented very well by the Dutch teams with their association with the Philips company and so forth. So there are a lot of forces at work there that are going to make it difficult to put an endograft in that you could guarantee will be in a satisfactory state for the patient's life, a lifetime rather.
Since you first used these clinically, there have been a tremendous number of modifications, from a tube graft in the aorta to a modular design and a branch design. This might, I would imagine, have brought to mind to you some need for modifications. And have you yourself developed patents, or have you developed ideas that have been implemented and that have been incorporated into the design of some of the endografts?
No, I've certainly had ideas, but I haven't gone down the path of applying for patents to them. But now that I've got a little more time on my hands. I think there's still one or two things that would be very useful to explore.
So when you see a need for a change in a device, how do you go about accomplishing that? Do you talk to the company that you're working with and suggest that they make the changes? And how do you have this evolution occur from what's a very primitive device initially when you first put it into a much more sophisticated, not only device, but the delivery system seemed to me to be markedly improved since the first one that you put in here?
Yes.
In your practice.
Yes, I think that's true. I mean, going back to the first one, it was not only a problem with getting a low enough profile delivery system. It was also a problem because the largest hemostatic valve that was available commercially then was 14 French, which was way too small to be able to put the endograft through, so that you had to pass the balloon through the 14 French hemostatic valve, and then load the rest of the stent and the endograft onto it on the patient's side of the valve, and then join that up with some plastic tubing to the sheath that was already in the patient. So it was very much a Heath Robinson type arrangement, but it was watertight, and it allowed us to do the job that we wanted to, or that we set out to do.
Tell us a little bit about the regulatory environment in Australia versus the United States, because you were able to do things in Australia that maybe we weren't able to do in the United States at the same time. And I've noticed that a lot of people go to Australia for training, and also that some of the grafts are made in Australia. Is that just coincidence, or is it a different environment where you work in Australia than in the United States?
No, I think you're right that the environment is different. We have it's called the TGA, the Therapeutic Goods Administration, which is charged with importing materials, and there is also, I think, a less stringent requirement on new devices that are developed, because in the case of the EVT device, if we just looked at that, for example, I think the regulatory restrictions that were placed on that being freely available as opposed to being used under the protocol, that meant that the people in the United States were finally able to get an endograft 6 years after most of the rest of the world had stopped using that particular endograft, which was still a good endograft if you could get it in, but there were problems with being able to be sure that you could get it where you wanted it to go. So I think that made Australia a logical place to go to for doing first in man or safety and efficacy in the new devices, because there was certainly restrictions and and regulations that we had to conform with, but they were nothing as rigid as the ones that you have in the United States.
So it sounds like an American company patented a device which was first used in Australia for patients, and it took almost 6 years for it to come to the United States, which I guess tells us something about our safety and efficacy balance, that we weighed safety so far over efficacy and the opportunity to use it that patients didn't get treated here for 6 years when they were getting treated in your country 6 years before that.
Yes, I think that's true. To be fair, I think Westmore had put in the first EVT device in Los Angeles before we put an EVT device in there, and the ones that I was talking about were ones that we were making ourselves back in 1992, and I think it was in February in 1993 that Wes put an EVT device in, and then we started putting them in I think September that year in 1993.
I see. So the difference wasn't that great, but you had a device to put into patients well before we did, of the comparable device.
Yes,
Yeah.
and that was why the EVT company had approached us to, as indeed they had approached the Dutch team as well. Mm. So we were both at that time putting in EVT devices.
Now, one of the common problems, or not common, but frequent problems, is the endoleak, the leakage of blood either around the endograft. It doesn't have a complete seal, or between the junctions of the different components, or even backflow through the collateral vessels. And maybe tell us a little bit about, I guess even through the device itself, there was some fabrics that allowed for fluid and blood to leak through that. Tell us about the endoleak issues and how you both identified them and started solving the problem of endoleaks.
I think the first thing that we were able to do as far as contributing to that problem was to report that endografts that were deployed and where there was a good seal proximally and distally with the native artery, that they shrunk over time, and those in which there was not a good seal expanded, and that was we first published that as a preliminary publication in 1994 and 95, I think. So it still took 3 years, which was surprising that it wasn't. I mean, it seems obvious now that it wasn't generally known, and then it also was due to Jeff White's contribution, I think, that the type of endoleaks were separated into those that were graft related and those that were collateral related, so just distinguishing between what we now know as type 1 and type 2 endoleaks. That was quite an important thing as well, and then subsequently to be able to classify the other ones so that everyone knew what they were they were talking about. But it wasn't all that easy to diagnose them either. I think in the early days it took a while to realise what the best modalities were to do that.
The purpose of endografts is to keep people from rupturing their aneurysms or requiring a big operation. And certainly it's minimized the extent of the operation. Maybe you could tell us about the first patient you put in and how long that individual lived, and also what the longest endograft was in a patient, or still is in a patient, that you've personally placed. In other words, how long do you extend life, both initially when you did it and maybe even today?
Yes, the first patient was still alive 3 years ago. That's the latest follow-up I have on him. He subsequently required an open repair though, but the longest patient that I still have alive with no problems from an endograft was put in 1995, so that's now
About 17 or 18 years.
17 or 18 years.
Terrific. And the difference that you've reported in mortality between the open repair and the endovascular repair, I don't know how many of these you've done, but have you ever calculated how many lives or how many years of life were saved by putting in endografts as opposed to doing open repairs, had this technology not evolved?
No, it would be an interesting project though to look at, because it should be possible to calculate that.
And is your experience now that endografts placed in an institution which has some experience in doing them have a less than 1% mortality with the endograft placement, with the procedure?
Yes, it's certainly around about that figure. There's still cardiac deaths that are sometimes hard to predict, so I'm reluctant to say that we've reached the sub 1% standard, which is quite important really, because that's the level that we'd have to achieve before we could justify lowering the cut-off point of 5 centimetres or down to 4.5 centimetres or even 4 centimetres to treat aortic enlargement prophylactically.
The endograft has revolutionized vascular surgery in many good ways for patients, but there's also a downside to it in that surgeons don't do as many open operations, and therefore when a patient needs it, they may not have as skilled a surgeon because they haven't been doing open procedures. Have you thought about any potential solutions to that problem, that you get a minimally invasive approach and don't do as many operations, and therefore when a patient really needs it, you might not have as good an outcome?
Yes, I think it's a major worry, and the trainees themselves have recognised it too, and several of them come to you and say that they just don't feel comfortable doing open operations and on AAA, and far less tackling a ruptured one. And I think the advice I give them is to try and become as familiar as they can with the exposure of the supraceliac aorta, the one that was developed by the Houston group, which involves an abdominal incision.
Like the Maddox maneuver, or Ken Maddox, or that approach?
That sounds as though it's the same one. You go through the right crus of the diaphragm.
Crawford.
Yeah, Stan Crawford was the person that I first saw using it, and it was made a huge difference to me personally at that time, because you could once you got a clamp on that, you could then open the aorta distally without any distal clamps, because the collateral was so limited that there was very little back bleeding. So I think that if you can train the fellows these days that are worried about their ability to do aortic aneurysm surgery, if you can arm them with the ability to be able to get a clamp through the right crus onto the supraceliac aorta, which is usually delightfully free of calcification and doesn't require any dissection to speak of, so that just having your two fingers either side of it's enough to guide a clamp down there. I think that would do a lot for their confidence. And whether we can do this, you're probably best done on a fresh cadaver or something of that nature, but even a model would be better than nothing. But it's an increasing problem. You're quite right.
So with this revolutionary change in vascular surgery, do you see other areas that are comparable as far as their impact on our specialty? What do you see looking forward that will be comparable to the endograft that you pioneered that will change vascular surgery in the future?
I don't know that there's anything that's going to change what we're doing as far as occlusive disease is concerned. I think that's a tougher project to master, although I'm sure you would agree the number of long bypasses that we're doing now is nothing compared to what it used to be in the 70s and the 80s. And I don't think we're amputating any more legs now than we were then, but we certainly still haven't solved the problem. But I don't think there's any magic bullet in there that I see.
Well, thanks very much for your contributions to just developing this whole field, because it has really had a worldwide impact on the way we handle aneurysmal disease.
Thank you very much.
Jim, now that you, as I understand it, you stopped going to the operating room, but now you have a primary role in teaching. Back in 1986 through 95, you were still chairman of training and accreditation for vascular surgery, and as well as being on the Court of Examiners for Vascular Surgery in Australia from 1996 to 2001. Do you find that making this transition to a more of a teaching role to be fulfilling and satisfactory as far as you're concerned?
Definitely. There's nothing like having enough time to teach after a career where you were always trying to fit teaching into the schedule with commitment to patients. So I've thoroughly enjoyed it.
You've mentioned some of your mentors, but perhaps you could tell us, with each of these mentors, what you found so attractive and helpful to you. J. Engelbert Dunphy. Exactly how did you find him to be, and how was he helpful to you?
He was, I think, helpful in many ways. He was a great role model in that he was able to run a department incredibly efficiently, and he was also an excellent chairman, as was John Lowenthal, chairing a meeting or chairing a morbidity and mortality session, which he did with great skill on Saturday mornings. And I think that he also had a good sense of judging people's worth and knowing who to encourage and keep on the staff. And just in the time that I was in the department, the ones that he had then have gone on to become heads of department and chairs elsewhere in the United States. So,
John Najarian.
yes, he was my supervisor when I was in San Francisco, and as you know, he was quite a formidable sight as a former American football giant in every sense of the word. But he was excellent, really, as far as exposing me to what you should be doing when you're supervising someone. He used to run a regular meeting every Friday afternoon, a research meeting where you had to present any project that you were planning to do so that you could save time by getting other people's input, and then you had to give progress reports, and also the all-important business of rehearsing any public dissertation on the research projects.
Sir John Lowenthal has been mentioned several times.
Yes.
What was your contact with him, and how did he influence your career?
My contact with him was again fortuitous in that he normally had this was when I was only a second year RMO, and he normally had a senior surgical registrar looking after him, but the one that he had there, it just happened that he was sitting for his final fellowship, and he was given time off to go to a course and to sit for it. And in that time, I was promoted to look after the unit for him as a second year resident, which I took the opportunity in both hands and did what he considered to be a very good job, I think, and that allowed me to be taken by him as his registrar subsequently, and also to be an advisor as far as my career was concerned, and arranging the opportunity to go and work with Dr. Dunphy.
You didn't mention John Anderson. Did you have any contact with Dr. Anderson?
John Anderson from Adelaide.
Right.
Yes. we're very good friends, and he was certainly streets ahead of the rest of us as far as his catheter and guide wire skills were concerned, and was doing that work early in the 1980s. That he I think really came into his own when the Cook Company were able to provide fenestrated grafts, because he did the early cases along with Michael Lawrence Brown. So the two of those did an excellent job with those early cases.
Jim, I'd like to ask you now, in this phase of the interview, some opinion questions.
Right.
Specifically, what you might think of what these areas might represent. We'd like to know specifically a little more about vascular surgery in Australia and your perception of vascular surgery in the United States. Is vascular surgery an independent surgical specialty in Australia?
Yes, it is. We spent a lot of time over a period of probably 5 years to achieve an independent state for vascular surgery, and that came about in 1995, and since then it's been a specialty in its own right, and we select our own trainees and examine them and so forth. And I think that's made a big difference, and it fortunately coincided, with the development of endovascular surgery as well, so that the whole thing was able to be managed more easily than it would have been if we'd still been under the general surgical umbrella.
You mentioned certification. You have your own system of certification then for vascular surgery.
Yes.
For endovascular training, do you use a simulator?
We have had the use of a borrowed simulator from time to time, but we don't have access to one on a permanent basis.
Now, what is your opinion of the merger of ISCVS North American chapter with SVS? Do you think this has had an effect on international exchange?
You're meaning that the people that you would come as an outsider coming in contact with vascular surgeons here, that those might be diluted with the joining of the two societies. I guess it's possible, but I hadn't actually thought that through.
SVS has a new category of membership, the international membership. Do you recommend this for your younger members of your program?
I haven't so far, but it's only through a lack of awareness of what the aim is and what the requirements are, to be quite honest.
SVS also has an international scholarship program designed for young vascular surgeons from abroad to broaden their horizons in vascular surgery by coming to the United States. This scholarship is fully funded, and they are invited to attend other annual meetings as part of this scholarship program. Do you think you might actively support this program?
Definitely. I think that the opportunities here exceed any other opportunities that I'm aware of internationally.
Dr. Yao, who wasn't couldn't be with us today, has asked me, has in fact given us a couple of pages of questions that he would like for you to address. And I've promised Jimmy I would do this. As the ambassador of vascular surgery from Australia, Jimmy would like to know your opinion on the current leadership role of American vascular surgery in the world. Are we in decline because most end technology is tested abroad and malpractice insurance here has driven many foreign visitors visiting vascular surgeons out of the operating room?
Yes, I think there's no doubt that the restrictions that have made it necessary to do the testing outside the country has had an effect on the standing of the vascular surgery in the United States.
We've yet been unable to address tort reform in this country, which I think has been a very negative effect, and also with international ripple effect. How do you see might be the best way to improve international exchange?
It's hard to say because Australia has probably, I think, a worse system than you have in terms of the requirements that you have to go through to get an overseas medical graduate, not so much to come in the observer role, that's not a problem, but to get them registered and so forth, so that they can scrub in and take and be involved in patient care. And it's tied up mostly with complicated classifications, which I'm not even sure that those that are working in the department have got a clear idea of what category you should be in, but it's incredibly frustrating because you can seek advice and find out what the category is from one person that you speak to in the department. You tell the potential candidate from overseas, and unfortunately the candidate visits an Australian consulate and they tell him another category that he should be registered in. And to make matters worse, when he arrives in the country, it's possible that the person making the final decision says that both of the original instructions were wrong and that you need a third category, and you end up with correspondence on each one of several centimetres. So it's I think the first thing to do is to try and get some way of short-circuiting that.
Jim, we'd like to ask some questions now more related to the United States and vascular surgery here and what your opinion might be. As you know, the United States healthcare system has become a political football, and notwithstanding now most recent re-election of the president, the country remains quite polarized in this issue. What system does Australia use with regard to healthcare delivery?
We've got a system where everybody, every citizen in the country and everyone with permanent residence are covered for free treatment only in a hospital. They're still responsible for their own treatment outside the hospital, so that once they need admission, then they can elect to be treated as a hospital patient rather than a private patient. The number of people that elect to take out private health insurance has varied over the years since the introduction of the free public system, and it's varied from being as high as 80% down to probably 30% or something like that, and currently I think it's running at around 40%. That's a guess, but I think that's what it. And that varies, of course, from what area you're talking about too. If a wealthy area, the proportion would be much higher.
Do you think the U.S. has lost our way?
It certainly seems that it's in need of something that it hasn't got at the moment. Because I understand that what the president has achieved in terms of availability for free hospital care is strictly limited to something like 30,000 or that. Am I incorrect in my information, or?
I'm not sure either, but I know that it's very controversial and convoluted, such that I hope we can achieve some reform that will help everyone. Another controversial area in the United States we'd like your opinion on is that of the vascular surgery's fight for independence from the American Board of Surgery. As you know, despite a very vigorous attempt, this fight for independence failed. What is your opinion on why?
There are still some people in the practice of vascular surgery in this country that see a virtue in general surgery,
Right.
and that there isn't a 100% commitment to becoming a standalone specialty, because I know from our experience that we had 100% virtually support for proceeding along. That's not quite right. There was one person that was still standing up and putting the opposite point of view. But,
I wish I could say we only had one person in the United States. Jim, to round out the interview, would you offer some advice to young vascular surgeons here in the United States?
Yes, I think I'd congratulate them on choosing vascular surgery as a specialty, and advise them to get as much training as they can still in open surgery while it's available, as well as their skills in catheters and guide wires.
Jim, thank you so much for allowing this interview and taking your valuable time to be with us today.
It's a pleasure, Roger, and thank you very much for your questions, and also the questions that you put from Jimmy Yao, and it was nice to see Peter Lawrence here too.
Right, tremendous. Thank you so much, Jim.